I think we are ready to get started. So, everyone, thank you. I know it's early in the morning again, but we are very, 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 very fortunate to have Dr. Cohen speaking to us. He is a fantastic infectious disease clinician and is going to be reviewing some pearls for STIs and UTIs. And this is one of our two infectious disease talks for today. So, Dr. Cohen, I will turn it over to you.
That sounds great. Thank you all. Good morning. Thanks so much for being here. It's great to be with you virtually. As Anant mentioned, I'm an ID doc at UW and direct the infection prevention program. Delighted to talk to you about this topic. Just a few pearls before we get started. One is just for infectious diseases when you're looking at radiology, it's usually not the most accurate test. It might help you with the syndrome, but it's not going to help you make a specific microbiologic diagnosis. So if that's one of the answer choices, it's probably not the one to pick. The others are when you're writing questions, it's super easy to write in risk factors for an infection. And we'll talk about some of those risk factors. But don't let those confuse you. Think about what is the actual presentation, what is the syndrome that you're dealing with, and then do those risk factors actually help push you in one direction or another? Just don't anchor on those because they can take you down. And then when the question is about treatment, usually in infectious diseases, beta lactams are generally the way to go, unless it's a zoonosis, in which case we're talking about doxy. And actually today we'll be talking about doxy quite a bit. Okay, so let's talk about cases. Now, I'll just put a disclaimer. These first three cases are about syphilis, and syphilis is very confusing. So do not feel badly if you feel like you're not sure where to go with these questions. It's exactly why we're talking about them. Okay, so first case is a 36-year-old man who presents to clinic with a new rash on his palms and soles present for 1 week. He denies dysuria or genital lesions. He has multiple anonymous partners over the last 6 months. And he's concerned that actually his hair's falling out and he's got new tinnitus and left-sided hearing loss. Okay, so I'll let you take that in for a moment. He's HIV negative. His labs show mild alk phos elevation, mild LFT abnormalities. His RPR is 1 to 256. And he gets a spinal tap, which is actually pretty bland. The protein is 35 normal glucose. And so the question here, so it's what we call a second order question. It's not just what is the diagnosis, but what is the treatment? And I'm just going to remind you, this is somebody who came in with a rash, has mild LFT elevations. In addition to all those symptoms, also has some ringing in the ears, and has an LP that's relatively bland. So I'm going to launch the poll if I can. Uh, Actually, Liz, I may need you to launch the poll if you don't mind. So is the correct choice A, doxycycline 100 milligrams POBID for 14 days, B, doxy and ceftriaxone, C, penicillin benzathine 2.4 million units times 1, penicillin weekly times 3, or continuous penicillin for 14 days. So let me know what people think. And again, this is hard. I realize most people don't deal with syphilis frequently, but okay, I love it. So people are thinking either 3 doses of penicillin or continuous penicillin for 14 days. And you're absolutely on the right track here. So the answer is actually penicillin for 14 days. But I can completely understand why people would have said, give it weekly times 3 doses. And let's talk about neurosyphilis. So just to be very clear, neurosyphilis can occur at any stage of syphilis, and the diagnostics are not very good. So even if the VDRL is negative, it doesn't necessarily push you away if you have a high suspicion. The spinal tap is usually shows some inflammation, but not always. And the symptoms of neurosyphilis are, it's a broad spectrum. You can get altered mental status, neuropathies, meningitis, but also just auditory or visual symptoms. And so the pearl in this case is if anybody has either visual symptoms or ear hearing symptoms, that is an indication to treat for neurosyphilis. So in this case, the patient had tinnitus. And so regardless of the spinal tap results, we're going to be treating them for neurosyphilis. And then, of course, if somebody has a penicillin allergy or they're pregnant, the treatment of choice for neurosyphilis would be desensitize and then treat with penicillin. Okay. So we're going to talk a little bit more. We'll go through a few other review questions for syphilis just to get the treatment algorithm down. But I'm going to do a quick brain break here and say, if somebody, you've got a question and the question involves spelunking or caves, what infection or infections might be associated with this activity? And feel free to type it into the Q&A or the chat, read them. So these are just sort of buzzwords for infectious diseases. Let me know what you think here. All right, and I see people saying things like histoplasmosis and rabies. That's exactly right. So in general, when you think about caves, think about histoplasmosis, the endemic fungal infection. Okay, all right. Next case, more syphilis. So this is a 36-year-old man who presents to clinic with a sore throat and new macular rash on his trunk and palms. This is very similar to the last case. Multiple anonymous partners over the last 3 months. His hair's falling out, but no other concerns. So very clearly, he says he doesn't have any visual complaints, no hearing symptoms. He's HIV negative, same labs. RPR again is 1 to 256. And so in this case, so for somebody again who just is presenting with a rash, high risk, and has a positive RPR, now how do you want to treat them? Is it doxycycline for 14 days, doxy and ceftriaxone, benzathine penicillin times 1, benzathine penicillin times 3, or continuous penicillin for 14 days? Let me know what you think. Hopefully this is a little more straightforward than the last question. All right, great. So I see a split between choice B, doxy and ceftriaxone, and D, benzathine times 3. So great thoughts. And I love thinking about doxy and ceftriaxone here, maybe because of the sore throat. That's what people are thinking about. In this case, it's not a trick question. He had a positive RPR. And so let's talk about syphilis. In this case, this is just good old-fashioned primary syphilis. And so let's talk about just how we break that down. So early syphilis is defined as less than 1 year of symptoms. Late or unknown duration is greater than a year. For early syphilis, it's just 1 dose of benzathine penicillin. So that means anybody with a painless chancre, early latent involvement. So you know the timing of when the encounter may have occurred and that exposure was less than a year. Or if people have secondary syphilis, so a rash, systemic symptoms, pharyngitis, those sorts of things. For late syphilis, that's when we give benzathine penicillin times 3 doses. So that's unknown duration or somebody with tertiary syphilis. And then, of course, neurosyphilis, as we talked about, can happen anytime during this continuum. But for somebody who's got the rash, a positive RPR, that's secondary syphilis, and they can just be treated with 1 dose of penicillin. Amazing how, syphilis has been around forever. Penicillin's been around for a long time. There's no resistance, and penicillin is highly, highly effective for this condition. Okay, so for treatment, if somebody has a penicillin allergy, and of course, except if this is pregnancy or neurosyphilis, doxycycline is the treatment of choice. And currently there's a penicillin shortage, so we're using a lot of doxy. Just remember that when you're treating syphilis, and this comes up on the boards all the time, you might get something called a Jarisch-Herxheimer reaction. So that's just systemic symptoms within 24 hours of treatment. Very, very common with early syphilis when you have a high burden of these spirochetes and you just keep treating through it. Okay, this is something that's in the news frequently. We're switching gears now. What do people think about raw milk? What sorts of conditions or infections might be associated with raw milk? Feel free to type it into the Q&A here. And don't worry, I'm the only person who can see the answers. So great, I love it. Somebody's saying listeria, that's exactly right. Brucella, that's exactly right. So all sorts of these zoonoses. And then, of course, we can get even, avian flu, which we know is affecting cattle, and just good old-fashioned E. coli and other things. So pasteurization exists for a reason. And that's you guys are right on it. Okay, last syphilis question, and this is about testing. And I'll just say this is a very confusing topic for everybody. And so we're just going to try to break it down a little bit. So this is very testable, which is why I'm raising it here. So this is a 35-year-old man. He's got malaise. He's got a macular rash over his torso. So this is kind of the same guy that we've been talking about for a while now, multiple anonymous sexual encounters. And he thinks he had a painless genital ulcer a few months ago. Okay, so very clearly, likely had primary syphilis a few months ago. Okay, no neurologic symptoms. Okay, so now you get these tests return, and so he's HIV negative, but he's got a positive syphilis antibody. His RPR is negative, and then the syphilis specific test, the FTA antibody, is positive. And that's a very confusing but clinically quite common pattern. He tells you he's never been treated for syphilis before. And so this question is really, how do we interpret these results in the setting of somebody who seems like had syphilis recently, or maybe hasn't? So what is the most likely explanation for these results? A positive serology, negative RPR, and positive syphilis-specific test. Is it A, he doesn't have syphilis? B, he's been adequately treated for syphilis in the past? C, it's too early in his infection for the RPR to be positive? Or D, the antibody titers are too high to be accurately detected? So let me know what you think. And then this is the last syphilis question. We'll move on to other topics. But I realize there's a lot of confusion around syphilis. So, all right, let me know what you think here. We'll talk about the syphilis testing algorithm in a minute. Hopefully it'll clear things up a little bit. Great. So we've got a spread of answers here from B, C, and D. And the majority of people got this. So this is antibody titers are too high to be accurately detected. And that's a known issue with this test. So let's just talk about this algorithm. If you've got a positive serology, so the reason they do that is it's very sensitive, but we see all sorts of false positives. And then if you've got a positive serology and a positive RPR, then you've got syphilis. You've got a laboratory diagnosis of syphilis. That is pretty straightforward. Those are, congruent tests. On the other hand, if you've got a positive serology but a negative RPR, then you've got some discordance and you need a tiebreaker. And so that's where the syphilis serology comes in. But there are different, it's the syphilis specific test, but there are a couple different ways to interpret this. Okay, and let's just break it down. So one is he's got previously treated syphilis. So that means the antibody stays positive and the syphilis specific test stays positive. Those can stay positive for a very, very, very long time. And that's why that's usually the most common scenario. In this test case, in the STEM, I said he's never been treated before. The other possibility is a prozone effect, and we'll talk about that. That's when there's actually too much antibody around, and so it interferes with the test. And occasionally you can get people who are tested too early, but that's a pretty rare thing. Usually these antibodies are pretty quickly. So what happens with the prozone is it causes a false negative RPR on the boards, and it just means there's super high antibody titers during secondary syphilis, and it just interferes with the assay. We don't need to get into the technical issue, but just know that if somebody has raging secondary syphilis, they can have super high antibody levels, and you just ask the lab to dilute the sample, and then you'll see this positive RPR come out. So in this case, this is just a prozone effect, easy for the boards to test you on. Okay, now we're going to totally switch gears, but first we'll do a quick brain break. What do you associate with roses, or maybe even somebody getting stuck with the thorn of a rose? Yeah, perfect. So if somebody immediately said sports trichosis, that's right. It's a fungal infection you can get from roses called rose gardener's disease. Okay, perfect. All right. So next case, This is a 63-year-old man with paraplegia due to spinal cord injury, is admitted for increasing cough and dysreflexia. He has an indwelling urinary catheter for neurogenic bladder and recurrent urinary tract infections, so probably not uncommon, something that we see clinically relatively frequently. He's febrile, he's insensate below the umbilicus, so challenging to get additional history or perform an exam on. And his UA has 4 whites, 1 red. Urine culture is showing a lot of Candida albicans. His chest X-ray shows a right lower lobe infiltrate, okay? And the renal ultrasound is normal. So just to be clear here, so this is, he's coming in with cough and dysreflexia. Those are his main symptoms. And then just as part of the workup, you see that he's got Candida in his urine, and he's got a right lower lobe infiltrate. So regarding his urine culture, what would you say is the next best step? Is it A, get a CT abdomen and pelvis, B, replace the Foley, C, start fluconazole, D, start micafungin, or E, get some fungal blood cultures? So what do people think about this? I realize this comes up pretty frequently. Saw this last week. And part of the reason this is so testable is that there are very clear guidelines around this condition. So let me know what people think. Okay, great. So most people sort of a split, fungal blood cultures and replace the Foley catheter. Excuse me. I'd say replacing the Foley catheter is the correct answer here. And this is a very common condition called funguria. And this is just asymptomatic candidaria in adults and generally does not require any treatment whatsoever. The time when we do treat it is prior to a urologic procedure. And it often resolves without any antifungal treatment. It just means the catheter is colonized. If somebody really has persistent candidaria and they're immunocompromised, then you might want to get upper urinary tract imaging. Sometimes they can have fungal balls in their kidneys. In this case, we had a renal ultrasound, which ruled that out. And so in general, additional workup, including fungal blood cultures, is unnecessary for somebody with funguria. In this case, the patient had a cough and they had a chest X-ray compatible with an infiltrate. So that's probably going to be your diagnosis. And this was just an incidental finding. So it doesn't need any additional workup. Okay. Um, I realize these are very cute creatures. They are all over my neighborhood currently. What condition is associated with these animals? Yeah, so it's exactly right. So great job with the buzzwords here. This is tularemia, something we don't see that frequently in part of the world where I live, but we see it occasionally in other parts of the country. Okay, so next case, and this is more on the STI end of the spectrum. This is a 39-year-old man who presents with rectal pain, fever, and tenesmus over the last week. So I'll just highlight this. This is a very testable condition. The board seemed to like this. Denies diarrhea, abdominal pain. He's had multiple anonymous partners over the last year and has had receptive anal intercourse. On exam, you find mild rectal bleeding, small painless perianal ulcerations, and rectal tenderness. So the first thing with an infectious disease question is just figuring out before you jump to a microbiologic diagnosis, just think, okay, what is the syndrome here that we're dealing with? And then let's think about if we can make a diagnosis. Okay. So the following return, he's HIV negative, syphilis negative, gonorrhea is negative, and his chlamydia test is positive from the rectal swab. Okay. So what is the most likely cause of his proctitis? Is it A, gonorrhea? Is it B, lymphogranuloma venereum, LGV? Is it C, chancroid? D, acute HIV? Or E, granuloma inguinale? Which one do you think? I realize this, for many of us may not come up clinically that often, but It seems to show up on the boards with some frequency. So people are thinking there's kind of a split between A, B, and C. I love it. So people who answered B are correct. So this is LGV or lymphogranuloma venereum. And just remember, it could have been a trick question, but his gonorrhea testing was negative, and we'll talk about chancroid in a moment. So just the syndrome here is acute proctitis, right? And so there are many infectious causes here, gonorrhea, chlamydia, syphilis, HSV. So typically STIs. Typically, the population are people who are having receptive anal intercourse. And if you don't have any labs, the empiric treatment is ceftriaxone and doxy for gonorrhea and chlamydia. So for mild proctitis, we often give doxy for 7 days. But for somebody who really has high risk behavior, we're talking about bloody discharge, you've got, rectal ulcers, a positive chlamydia test. That's concerning for something called LGV, lymphogranuloma venereum, and that's when we use a longer course of doxycycline. So here the diagnosis is actually important. And LGV is caused by a different strain or serovar of Chlamydia trachomatis. So it's the testing for chlamydia will be the same. It'll still say a positive test, but it doesn't distinguish between that serotype. And although we see it in subtropical regions, we've actually seen very large outbreaks across the United States. And our current testing doesn't differentiate LGV from other types of chlamydia. So in this case, you just have to say, okay, there's a positive chlamydia test. And clinically, this feels a lot like LGV. And LGV has kind of two different syndromes. One is just an anorectal syndrome, which we talked about here, pain, rectal discharge, fever, tenesmus can look a lot like inflammatory bowel disease. LGV can also present with painful inguinal nodes, and this is very, very inflammatory. So other types of chlamydia actually may be less inflammatory, which is why people can have these kind of chronic subacute chlamydial infections that may not even know it. Okay, so that is LGV. Just think about proctitis in somebody with high risk sex. And remember that doxy should be given for an extended course if you're suspecting LGV. All right. So we're going to change gears again a little bit, give you a brain break. So what is the association with cat bites? What infection are you thinking about here? And the challenge with cat bites is like 90% of them get infected. And so, if this comes up on the boards, there's a strong indication to give prophylaxis for cat bites. That's in contrast to some dog bites. The organism here is we're thinking about Pasteurella. That's usually the buzzword. Um, Bartonella can happen, but of course that's more with cat scratches. So Pasteurella and other just mixed oral anaerobes for cat bites. Okay, so let's do the next case. I suspect this may sound familiar to many of you. So this is a 90-year-old woman who lives in a nursing home, and her family reports that she just doesn't look quite right. She has chronic incontinence. She has chronic dysuria. There's been no change in her symptoms. And staff note that she doesn't have any mental status changes, no fever, no suprapubic pain. Her UA, she's got 3+ leukesterase, 3+ nitrites, no squamous cells, and her urine culture grows greater than 100,000 E. coli resistant to ampicillin. So again, this nursing home resident doesn't look quite right. She's got these chronic symptoms. And the question for you is, how do you want to manage her? So what's the next best step? A, do you want to start ciprofloxacin? B, do you want to start nitrofurantoin? C, do you want to start piperacillin tazobactam? D, supportive care? Or E, get a CT of her abdomen? So let me know what you think about this. We're going to probably go through another case or two and then wrap it up. So I love it. So there's a bit of a spread here. A lot of people are trying to think about, do we start antibiotics versus do we start, does she just need supportive care? And the answer here is actually supportive care. So this is just taken directly from a JAMA rational clinical exam about asymptomatic bacteriuria. And this is an important concept because the boards really want you to know when to hold antibiotics. So I think you all know that pyuria is very, very common. It's basically a coin flip, as to whether people in a nursing home may have pyuria and bacteriuria. So it's a terrible diagnostic tool and has a very, very low positive predictive value in this population. And so particularly in this population, but in adults in general, the diagnosis of a UTI, it's really driven by people who have new lower urinary tract symptoms or constitutional symptoms without another explanation that doesn't respond to supportive measures like hydration. And so in this case, the boards really love asymptomatic bacteriuria. There are clear guidelines to hold antibiotics. This is somebody who, even though the family says they don't look quite right, her symptoms are stable, chronic, and you can start with supportive care before escalating to antibiotics. So I suspect in this patient's case, her urine is always going to be quote unquote positive, and it's not informative about what her actual diagnosis is. There are times when we treat asymptomatic bacteriuria, this is for pregnant people, or before a urologic intervention with anticipated mucosal bleeding. And other indications are controversial, and I think they're unlikely to be tested on the boards. Okay. I think we've got time for maybe one more case here. This is a 27-year-old with a painful penile ulcer, recently engaged in sex tourism abroad. And on exam, he's got this ulcer with irregular borders. It's tender. There's a purulent base, and he's got tender lymphadenopathy present. Okay, so this is just kind of pattern recognition, something we almost never see here in the US, but seems to come up on the boards all the time. So the question is, what do you think the diagnosis is here? Do you think it is A, syphilis, B, acute HIV, C, chancroid, D, lymphogranuloma venereum, or E, granuloma inguinale? Let me know what you think. I'll just let you know, this is one of those zebras that, I often don't think about until I see it on the boards or on a test. And for whatever reason, I think it's just easy to write questions about it. Great. So the majority of people got this. This is chancroid, so that's exactly right. We'll just talk about chancroid briefly. And just thinking about genital ulcers, there are only two types of painful genital ulcers, chancroid and HSV. And so if you can remember that, I think you'll get almost all the questions right on the boards because they'll typically tell you in the stem, is it painful or is it painless? There are some non-infectious causes or recurrent causes of ulcers that you can see below here. The painless ones are LGV, which we talked about, granuloma inguinale, which is so rare, I think it's unlikely that you'll be asked about it, and of course, syphilis, which is the classic painless one. So for chancroid, it's caused by Haemophilus ducrei. We've seen really its huge decrease in US cases. So typically the person on the boards will come back from somewhere in an endemic area, either in the Caribbean or Africa. Labs are usually not available, and so they'll just give you buzzwords, tender genital ulcer, suppurative inguinal nodes, or inguinal, lymph nodes. Okay, I think we're going to stop there, but I'm just going to skip ahead. There are several other cases that you are more than welcome to look through, but I'll just say you're going to do great on the boards and really appreciate you being here this morning. So thanks so much. And if you have questions, I'm happy to stick around.
Thank you so much. Fantastic as always.